Our next speaker is Dr. Ami Desai. Sorry, but your intro's from last year. she, You're probably better at it, yes. She's an attending physician at Comer Children's Hospital at the University of Chicago. Dr. Desai earned her MD at Robert Wood Johnson Medical School and completed her residency at Yale New Haven Hospital and her fellowship at Children's Hospital Philadelphia. Her areas of expertise are sarcomas and neuroblastoma and other solid tumor cancers, as well as developmental therapeutics in adolescent and young adult cancer care. She is a member of numerous organizations, including ASCO and COG. She is involved in many clinical trials at Comer Children's and others within COG and NAND. And what we do, normally Ami is our first speaker, and she's going to be talking about the neuroblastoma basics. And basically, her talk is more geared to those that are newly diagnosed, because many of you obviously have been through, treatments, relapse treatments. So we're a little out of order just because of scheduling with A&R speakers. But Ami's going to talk about the neuroblastoma basics.
Thank you, Pat. And I promise to get everyone to lunch. All right. These are my disclosures. So as many in this room know, neuroblastoma is the most common solid extracranial malignancy in children. So other than brain tumors, then comes neuroblastoma. It originates from neural crest tissue, and that tissue traverses anywhere from the neck into the pelvis. The most common site of disease is the adrenal glands, but again, we can see masses anywhere from the neck into the pelvis. And there is a broad spectrum of clinical behavior, which is really reflective of the biology of the tumor. So patients who have low-risk disease may be observed or just need surgery, where patients with high-risk disease need multimodality therapy. There are about 700 to 800 new cases of neuroblastoma per year in the US, and approximately this makes up about 8% of all childhood cancers. Half of all of these newly diagnosed patients will have high-risk disease, and there is a higher prevalence of high-risk disease in Blacks and Native Americans. And if you look on the right, this is really a disease of infancy and childhood, as you look through the red line, where it peaks in the earlier years and really tapers off by age 10. So one thing families always ask when I meet them for the first time is, why did this happen? And I wish we knew the answer. There is no consistent environmental factor identified. There's about family history in about 1% to 2% of patients. And then there's bilateral or multifocal disease without a family history in about 3% to 4% of patients. So I just want to start off by talking about somatic mutations and germline mutations before I go into the next half of this slide. So somatic mutations are mutations that we just see in the tumor, and germline mutations are mutations that we see in all of the cells in our body. So this is something that can be inherited, or it can occur de novo in a patient, perhaps while growing in utero, and where a patient is identified for the very first time within their family. So the two most common predispositions to neuroblastoma that we think about is having a germline ALK mutation or having a germline FOX2B mutation. However, over the years, there have been many syndromes that have been associated with a predisposition to neuroblastoma, and this list is not all-inclusive, but it is a list that the most recent expert panel suggested surveillance screening for. So this includes Costello syndrome, Beckwith-Wiedemann syndrome with this particular CDK-N1C germline mutation, not all patients with BWS, Weaver syndrome, duplication of 2p24, and Rohat syndrome. So for these populations at risk, what are the screening recommendations? As you can see, screening is really active in the first 6 years of life, becomes a little bit more spread out between ages 6 to 10, and then after year 10, where we really don't see neuroblastoma as frequently, no screening is recommended. But then that brings up the question, is there a role for screening in the general population? And there have been population-based screening studies in the past where urine HbA or urine catecholamines were measured in very young children. And what they saw was that there was an increased rate of diagnosis, but these were very early stage, no decrease in mortality, and that virtually all of the tumors had favorable histology and either would have regressed on their own or not progressed to a higher stage. So in conclusion, the tumors diagnosed in infants by mass screening are unlikely to progress to life-threatening advanced stage disease, and many are likely to spontaneously regress. As for the clinical presentation, as we talked about, this is a very heterogeneous disease, and some may just have an asymptomatic mass in their neck. If it compresses a certain ganglion in the neck, you may see Horner syndrome or a small pupil or droopy eyelid on that one side. For patients who have paraspinal masses that might go into the spinal space, there might be spinal cord compression, which may manifest as back pain or neurologic deficits. Sometimes we'll see a big liver, patients being pale if their bone marrow is heavily occupied by neuroblastoma, skin lesions. For patients with high-risk disease, often we'll see systemic symptoms, as well as bone pain and raccoon eyes, as in this picture. So I mentioned earlier that neuroblastoma is really a disease of infancy and childhood. However, it can happen in the adolescent young adult population, but the phenotype that these patients have is very different than some of the younger children. So again, it's a rare population, less than 5% of neuroblastoma diagnoses, and it tends to have a more indolent disease course. So patients may not get sick very fast, but they may have disease that isn't always very responsive to the therapies that are given as well. They do have inferior outcomes compared to younger patients, and there is certain unique tumor biology characteristics. And there is definitely a need for novel therapies for this group of patients. So evaluations and tests. We, of course, always start with a very thorough history and physical exam. We check baseline labs, including urine catecholamines, urine HbA/VMA. These are not always elevated in every patient at diagnosis. However, if it is, it's something that's helpful to follow over time. We will do a CT or an MRI for imaging of the primary tumor, and then an MIBG scan, which I'll get into in the next few slides, versus a PET scan for patients who have MIBG non-avid disease. And then to get the official diagnosis, we will get a biopsy as well as do additional staging studies with bone marrow. So we diagnose neuroblastoma by two criteria, either one, unequivocal pathologic examination of tumor tissue, or unequivocal tumor cells in the bone marrow combined with elevated urine catecholamines. And often some patients may be too sick to undergo a biopsy, and this is how we come up with our diagnosis. All right, so just a brief primer on MIBG scans. So MIBG is an analog of norepinephrine. It's labeled with radioactive iodine and taken up by neuroblastoma cells. And that little bit of radioactive iodine helps the disease light up on the scan. As I mentioned, about 90% of neuroblastomas are MIBG avid at diagnosis, and about 10% are not. A Curie score is a way for us to describe how much disease or quantify disease burden. What we see on the scan is normal uptake in the salivary glands, bladder, and liver, and we don't worry so much about some of these areas. And as Dr. Bagatelle mentioned, this does require thyroid protection in saturated solution with potassium iodine, or SSKI, where the thyroid takes up the SSKI so that it does not take up the MIBG with the radioactive iodine, which may put you at risk for hypothyroidism in the future. So this is someone we like to call Curie Man, which helps us, again, quantify how much disease that we are following and to follow that over time. So sectors or regions 1 through 9 are bony sites, and then sector 10 or region 10 describes the amount of soft tissue. So there have been a lot of neuroblastoma prognostic markers you heard from earlier talks today that help us risk stratify disease. So the first two, of course, were stage and age by Dr. Audrey Evans, and then moving forward was MCAN, ploidy, and histology. And those are the 5 we commonly think about. However, in more recent years, segmental chromosomal aberrations have also come into play and are part of the new risk classification system. So again, the 5 factors we think about: age of diagnosis with a cutoff of 18 months, stage, MCAN status, whether it's non-amplified or amplified, histology, whether it's favorable or unfavorable under the microscope, and tumor cell ploidy or DNA content within the tumor cells, and that is between a DNA index of 1 or greater than 1. And then this we put together to come up with risk classification. I'm not going to go through this in too much detail, but I just wanted to bring up one point that for a patient who is a little bit older, 18 months or older, who has metastatic disease at presentation, that patient is automatically categorized as having high-risk disease, despite the tumor biology. So most recently, we've been using the INRGSS, or the International Neuroblastoma Risk Group Staging System, which is different than the INSS staging system. And this is a pre-treatment staging system and really based on image-defined risk factors. And it has somewhat simplified the way we do staging for neuroblastoma. So an L1 tumor is a localized tumor without image-defined risk factors on scans. An L2 tumor is a local regional tumor with one or more image-defined risk factor. A stage M tumor is a patient whose disease is metastatic. And stage MS is a stage for children who are less than 18 months who have limited metastatic disease, and an L1 or L2 tumor. So these, I'm not going to go through this in detail either, but these are examples of image-defined risk factors. So the radiologist will look at, is the tumor pressing on any important structures nearby or blood vessels, and that's how we distinguish between an L2 and L1 and L2 tumor. And this is our new risk classification system for neuroblastoma through the Children's Oncology Group. And again, I won't go through the algorithm in much detail, but for L1 tumors, risk, age, tumor size, extent of surgical resection, MICAN status helps classify disease from low to high. And for L2, M, and MS tumors, we are looking at age, MICAN status, histology, ploidy, and segmental chromosomal aberrations. So our current treatment approach is to really tailor treatment according to the predictive behavior based on clinical characteristics and tumor biology. So again, this is risk group in a nutshell. So I think it's hard sometimes to hear, my child may have low risk disease, intermediate risk disease, high risk disease. But I think of risk group as telling us how much therapy we need to give to a patient to try to get to the best outcomes. And I'm just going to pause here and go a little bit through clinical trials, which you've heard a lot about this morning. But clinical trials are studies that involve people that help make progress in preventing, diagnosing, and treating cancer. And a lot of the conference in the next day or two is about really these therapeutic clinical trials. And each clinical trial follows a set of rules and a protocol that describes who can participate in the study, what treatment is given, and how patients will be kept safe and how treatment will be monitored. And clinical trials are the most reliable and accepted scientific method to find out if a new treatment works better than the current standard of care. And it is important to learn a lot about clinical trials when you meet with your providers. This is at diagnosis, at relapse, and these are just some questions that I think are important to ask. What clinical trials are appropriate for me or my child? What is the purpose of this clinical trial? What are the objectives? Why does the research team think that this might be something good for this disease? What is what we call the rationale for the study, or any hypothesis as to why this may work? What is the specific approach being studied? What other treatment options are available, including other clinical trials? And I think it's good to be informed about all the potential options. And then who or what organization is sponsoring the clinical trial? Who can participate on a trial is determined by inclusion and exclusion criteria. These criteria are based on a person's age, type of disease, medical history, and current health. And inclusion criteria help keep the population of the patients in the study somewhat, at least medically similar or homogeneous. Everyone comes in with a particular organ function, things like that. And then exclusion criteria really help keep people safe. So just very briefly, there are a phase 0 and phase 4, which I won't go into today, but these are the 3 phases of trials you may come across. A phase 1 trial is a clinical trial that tests a new treatment in a small group of patients or people to determine the appropriate dosage of the drug and safety profile. So we often will start at a low dose, treat a few patients. If there are not excessive toxicities, the dose may be escalated for a few dose levels based on how the study is being designed. And it may go to the highest dose level or a dose level plus taking into consideration drug levels as well. And it really helps us define the safety for a study. Often in pediatric patients, these drugs are studied first in the adult population, but that's not always the case. For phase 2 trials, now that you have the right dose of drug, we're looking at what is the efficacy of this treatment or treatment regimen? How many patients have disease that responds to this treatment? That's really the goal of the phase 2 study. And then phase 3 clinical trials compare the new treatment with standard treatment in a large group of people, and you heard about some of these this morning as well. So not to belabor much of what has already been spoken about, but phase 3 clinical trials are really what you see in the new diagnosis frontline setting. And it compares a new treatment that has been shown to be promising, which may have been promising in the relapsed or refractory disease setting, and then tries to challenge the current standard of care. So data are gathered from a large number of patients to find out whether the new treatment is more effective and possibly has fewer side effects than the current standard treatment. Phase 3 trials are usually randomized, not always, and patients receive either the investigational agent or are randomized to standard of care in a non-ordered way. So again, the investigators don't know it's the computer system that says, okay, this patient is randomized to this arm or this arm based on how the trial was designed. And I just wanted to go through a few legacy studies to show some of the progress that has been made in the field. And for low and intermediate risk neuroblastoma, the 2 trials I'm going to go over really show that we have actually been able to decrease therapy for some patients. So this is a phase 3 trial for low-risk neuroblastoma, where the primary objective is to demonstrate that surgery alone would achieve a 3-year overall survival or maintain this excellent overall survival for patients with asymptomatic lower stage neuroblastoma. So asymptomatic patients would get surgery alone and no additional chemotherapy, and indeed they were able to maintain this excellent survival. And for intermediate risk neuroblastoma, the last published study was ANBL 0531, and this looked to reduce therapy for subsets of patients using biology and response-based algorithm to assign treatment duration while maintaining a 3-year overall survival greater than or equal to 95%. And they used various criteria, again, these biologic factors, favorable and non-favorable factors, and response in patients got anywhere from 2 to 8 cycles of therapy plus or minus surgery. And indeed, they were able to maintain excellent survivals for this group of patients. And on the right of the screen, they also looked at the long-term results of this trial, and these results have persisted. For high-risk neuroblastoma, there's also been a series of trials that help define the current, in this context, the current COG standard of care. So CCG 3891 looked at continued chemotherapy after induction versus high-dose chemotherapy and stem cell rescue. And in this study, myeloablative chemotherapy plus autologous stem cell transplant improved event-free survival. COG ANBL 0032 that Dr. Bagatelle alluded to looked at introducing immunotherapy or anti-GD2 antibody to the last phase of therapy or in post-consolidation. And they compared this to isotretinoin alone, which was the prior standard of care. And the study actually closed early when a 2-year event-free and overall survival was improved with the addition of immunotherapy. And ANBL 0532, the last published high-risk study, looked at single versus tandem transplant, where patients randomized to tandem transplant after induction had improved event-free survival compared to those randomized to single transplant, especially when followed by immunotherapy. And one point I want to bring up as well, too, is when we talk about survival and when folks are talking about studies, you want to know from what time point survival is being measured from. Is it from enrollment on the study? Is it from this time of randomization? And that's just something to keep in mind as you hear about trials. So this again led to what we consider the current COG standard of care. And again, our speakers this morning talked about new trials that are in the pipeline to potentially change what we do. I wanted to bring up also maintenance therapy with DFMO after the completion of frontline therapy. So DFMO is an irreversible covalent inhibitor of ODC1. It depletes essential polyamines necessary for tumor survival, enhances chemosensitivity, and has immunomodulatory effects on the tumor microenvironment. And that was one reason why this was added to chemoimmunotherapy in the ANBL 1821 study, where they looked at chemoimmunotherapy versus chemoimmunotherapy plus DFMO that will be presented at this meeting. But that was some of the rationale for that study development. And then also when thinking about the frontline setting, there was a phase 2 study of DFMO following post-consolidation immunotherapy in patients in remission. This was a single-arm study where then the results of that study were compared to historical controls of robust historical control of patients being treated on ANBL 0032 using propensity score matching, which showed improved survival for those who did receive DFMO post-consolidation immunotherapy, and this led to FDA approval of this agent in December 2023. So all of these trials led to incremental approval in outcomes for patients with high-risk neuroblastoma, but we know we need to do better. And that's where some of the new trial developments are ongoing to continue to improve the curves that we see on this screen. All right, I'm going to skip through this because this Dr. Bagatelle went over this morning. And then I just wanted to go through a few targeted therapy highlights, and hopefully we'll introduce some topics that you will see over the next 2 days as well. So GD2 is ubiquitously expressed on neuroblastoma and is a great target for this disease. So we'll highlight a few ways that it's an immunotherapeutic target. I-131 MIBG therapy, radiopharmaceutical, and ALK inhibition. So most people in this room are familiar with anti-GD2 antibodies. There are various commercial antibodies, including dinutuximab beta, and naxitamab. The side effect profiles tend to be more allergic type reactions and pain. GD2 is expressed on long nerves. And so we know that there is this infusion-related pain, and we try to mitigate this as part of the treatment cassette. In the frontline setting, this is used in the post-consolidation setting, but also now is being investigated as part of induction, as was discussed earlier. And it really is an important agent in the relapse refractory setting where many of these anti-GD2 antibodies have been combined with chemotherapy and often used in the first relapse setting. And I should also mention, when I say refractory disease, I mean disease that may not have optimally responded to therapy in the frontline setting or after getting a particular type of treatment where there still may be residual disease. And then GD2-directed CAR T-cell therapy is something else you'll hear about during the next 2 days as well by Dr. Meisner. All right, so MIBG therapy, the concept of this is very similar to MIBG scans, except the MIBG tracer is attached to a much higher dose of radioactive iodine that essentially allows you to provide radiation, focal radiation to sites of disease. It requires a lead-lined room or shields to help protect family and staff from radiation exposure. And this is just a picture of our MIBG room at our institution, where we have the kids draw on the floor and sometimes the walls to make the room a little bit more comfortable during their stay. This generally requires stem cell rescue after treatment. The bone marrow cells are very sensitive to MIBG, so often we will try to give stem cells about 2 weeks after MIBG infusion to help marrow recovery. And this is a treatment we talk a lot about in the relapsed or refractory setting, but as again was discussed as part of ANBL 1531, is also when something is active in the relapsed or refractory setting gets investigated as part of the frontline setting as well too. And so this at a lower dose was given in induction on ANBL 1531. And this is just an example of a patient who had multiple sites of disease that cleared nicely and when we do scans, which is about 6 to 8 weeks after MIBG therapy. And we wait 6 to 8 weeks so that the MIBG is out of the body by that time, and we're not actually looking at intensified areas from the therapy. And then targeting ALK. About 14% of children with high-risk neuroblastoma have a tumor with an ALK aberration at diagnosis, and more recent studies suggest that this actually might be a tad higher than what was previously reported. Crizotinib was an ALK inhibitor previously investigated in the early phase setting and was initially part of ANBL 1531. And more recently, lorlatinib, a third generation ALK inhibitor, was investigated as part of a NAN study that Dr. Marichelian will review during this afternoon. And this helps set the stage of adding or switching out lorlatinib in place of crizotinib on ANBL 1531 Arm E. And again, as everyone has spoken about this morning, we are very aware that many of the therapies that we give do have have long-term impacts for our patients. And we really want to understand what these late effects are. So as we're developing new trials, they can be kept in consideration and try to be minimized as much as possible. And you will hear more about the LEARN study and survivorship by Dr. Diller during this conference as well, too. But their study, the late effects after high-risk neuroblastoma, or LEARN study, really wanted to identify what are the incidences of certain late effects in current era therapy. So patients were enrolled who may have been treated after January 2000 and went through really rigorous testing of all organ systems, collected a lot of data about treatment exposure to really get the nitty-gritty of what goes on after therapy. And so, again, Dr. Diller will go through some of the preliminary results that hope to be published soon, and we'll talk about next steps on how they want to follow our patients with future trials. So I'm just going to end by saying there is a lot of really excellent research going on that you're going to hear about over the next 2 days. This was really just a brief overview to give you a taste of what you may hear over the next 2 days, but we know we are all aware that we need to investigate novel therapies and really work together with laboratory researchers and clinicians to really develop novel clinical trials and novel clinical trial design that hopefully will help expedite the way we complete our trials. We want to further refine risk stratification to provide more precise treatments to our patients. We want to understand what these biomarkers of therapy response and resistance are, and you've heard a lot about that this morning as well. Patient-reported outcomes are being incorporated into a lot of the trials because we do want to understand the patient experience and, again, integrate that as we develop future trials. And then there is a lot of work going on in the field of social determinants of health, how race, ethnicity, poverty, everything, how your access to certain treatments, how all of this may impact your child's care, and how can we be better in treating all of our patients. So I just want to end by saying thank you to all of our patients and their families, and to really Pat and the whole CNCF team for putting this conference together and really having patients and parents advocate and learn more about what is going on in the field. Thank you.
Thank you, Dr. Desai.